Okay, as I alluded to last lecture when I started talking about antibiotics, we've got to talk about resistance to drugs, and this is a toughie in terms of something you're going to have to deal with, and it's getting worse and worse and worse. Okay, so once upon a time, there you go. Fleming discovered the miracle of antibiotics. And as I mentioned, almost as soon as we started using these antibiotics, we started seeing resistance. Okay. Penicillin given to the first patient in 1941, resistance in 1942. Okay. Penicillin given in 1960, resistance in 1961, and so on and so on and so on and so forth. And seriously, as soon as we introduce a drug, within about a year, we start to see resistance. Sir Alexander Fleming, British, said the microbes are educated to resist penicillin, and a host of penicillin-fast organisms is bred out. In such cases, the thoughtless person playing with penicillin is morally responsible for the death of the man who finally succumbs to the infection with the penicillin-resistant organism. I hope this evil can be averted. We wish. Not gonna happen. So what are multi-drug resistant organisms? And these are organisms that have developed resistance to one or more classes of antibiotics. And so these antibiotics can't be used effectively to control them or kill them. These are predominantly bacteria, but they can include viruses and fungi and your protozoas. But predominantly where we're having the problem is the bacteria. And the names of some of these multi-drug resistant organisms are resistant to only one agent, but they are frequently multi-drugged resistant. So you can have methicillin-resistant Staphylococcus aureus that tells you it's methicillin-resistant, and it's the name of it identifies the resistance to only one drug agent. But MRSA is resistant to a lot of other drugs. The same thing with VRE, vancomycin-resistant enterococci. So just because it says it's methicillin-resistant or the name of the drug is in there, something resistant organism, doesn't mean that. Usually means it's resistant to a whole lot of other ones, but it is resistant to the one that we have been generally using. Okay, that's what happens. Some of the more challenging ones that we have, you can see the list, and we'll talk about this, but they're getting pretty bad. They're getting to be very challenging in the healthcare, and this is the latest list that we have, and again, we add more every day. They're not a new problem. As I mentioned, Staph aureus developed resistance to penicillin in the late 40s and throughout the 50s. Methicillin was introduced to counter this, and we saw resistance. In 1961, as a first strain, we saw MRSA, methicillin-resistant Staphylococcus aureus, and this has been a problem. It was identified in Britain in 61. The first case in the U.S. was 1968. And again, MRSA is a beta, we're talking about beta-lactam drugs that have been used to treat it. Methicillin, penicillin, these are beta-lactam drugs. It is resistant to all beta-lactams. And we started using other drugs. In 2002, we had the first strains of Staph aureus resistant to vancomycin. They are still currently fairly rare, but again, you start using a drug and you're going to get resistance to it. Now, I'm going to go through some of these guys that we have problems with. What is MRSA? I'm sure you've heard MRSA. Everybody has heard of MRSA. It is a type of Staph aureus, methicillin-resistant Staphylococcus aureus. So it is a Staphylococcus aureus that is resistant to certain antibiotics, the beta-lactam drugs. Okay, and you need to recognize and receive treatment in the early stages so that you reduce the chances of the infection becoming severe, because it's going to be hard to treat. Most of the severe, possibly life-threatening infections with MRSA usually occur in a hospital setting. You can get a bloodstream infection, surgical site infection, or pneumonia. That's generally what it is. Now, according to the CDC, these more serious infections have been declining in the hospitals for several years because we've been just anal retentive, if you will, about trying to get rid of the MRSA in the hospitals, but it's still around there. We do classify them as hospital-acquired MRSA and community-acquired MRSA. That is the problem now. It used to be that MRSA was only found in the hospital facilities or nursing care, that kind of thing. It has now moved out into the community where you can get it in schools and that sort of thing. Now, the difference with MRSA, most of the infections are skin infections, and they are pustules or boils, and they often red and swollen and painful and pussy, and you've got all this nasty looking drainage. I'll show you in a second. They can look like spider bites, and they commonly occur at sites of skin trauma, such as cuts and abrasions and that sort of thing. Okay, there it is. You can see the spider bite. There's the MRSA, and you can see MRSA versus a regular staph. There's a big difference. It just gets nasty. You have to be very careful. Again, now we're seeing in hospitals, people are going and getting in a healthcare facility UTIs with MRSA. And so, it's something you need to be aware of. It's something that if your patient has MRSA and that patient can be released to home, you need to let whoever they're going to let them know. I will give you an example. My mom broke her hip and she went from the hospital to a rehab facility and stayed there for a few weeks because she was elderly. And, she couldn't rehab at my house. And when I went to pick her up, I picked up all the stuff and they gave me a prescription. I didn't look at it. And I went to the pharmacy and I saw the prescription. I'm like, what's going on? So I actually called the pharmacy, and not the pharmacy, I called back to the rehab facility and said, why is my mom being prescribed this antibiotic? I knew the answer, but I wanted them to say it. They said, oh, she has MRSA. I said, do you realize you didn't tell me about this? Nobody gave me any information? Yeah. I wasn't real happy. And I will tell you, I went to that rehab facility's administrator and kind of chewed them out. Rightfully so. I mean, this kind of information needs to be given to the patient because you don't know what the home situation is. So if you're working in a facility and you're releasing a patient with these kind of disease, let these people know. Luckily, I understood what it was. The person that was taking care of my mother during the day when I was working, when I was teaching, had end-stage renal disease. And I'm like, we got to protect her. Okay. So those kind of things can become important. So if you send home patients with these antibiotic resistant diseases, you need to let the families know, because they could have somebody at home that may not be able to tolerate these lovely little organisms too well. Okay, so MRSA is a big problem. It's in the community, it's in the schools, and we are watching it very carefully. The other thing that we have run into is VRE. vancomycin-resistant enterococcus. The enterococci, as we talked about, are bacteria that normally present in the gut, female genital tract, the environment, but they can cause infection when they get moved from an area that is not their normal area. For example, if you get E. coli is in your gut, but it's very common to get a urinary tract infection with E. coli because those bacteria can get up into the urethra. We'll talk about that when we get into the diseases. Vancomycin is an antibiotic that is used to treat some of the drug-resistant infections caused by enterococci. Now we have seen enterococci that have developed resistance to vancomycin. So we have VRE. This is an example of it. Yeah, it's really lovely. Okay. So, where does VRE cause infection? How is it transmitted? It lives in humans again without causing the disease. It colonizes. It can be found in the feces. Sometimes it causes infections of the urinary tract, the wounds. It's often associated with catheters or surgical procedures. It is generally passed from person to person by contaminating hands. It can live on a surface for up to almost 2 months. It is not spread in the air by coughing or sneezing or anything like that, but that is how it can be spread. So you do need to be careful. We usually see it like surgical wounds and that sort of thing. The risk factors for VRE is previous treatment with vancomycin, long-term exposure to antibiotics, extended hospital stays, weakened immune systems, surgical procedures, particularly abdominal and chest surgeries, and people that have indwelling medical devices, central intravenous catheters, ports, urinary catheters, that sort of thing. Okay. Now, we get into a little more difficult, guys. These are the extended spectrum beta-lactamases. So you know this is related to our lovely little beta-lactams. These are produced by gram-negative bacteria that were previously treated with vancomycin. And you have long-term exposure to these antibiotics. Yeah, look at this, vancomycin, quinolones, levaquin is a good one, piperacillin. And it usually develops after extended periods of hospitalization. Again, weakened immune systems, the same thing. But that means that in addition to these guys, the number of drugs that you can't use is extended. Okay? I can't spell extended spectrum, can I? Goodness gracious. Let's try that. My goodness, my typing is horrible. All right, so it just realized that they're produced by these gram-negative bacteria, and they do cause these problems. And again, we're starting to see these now more so than ever. And yeah, I'm not liking to see these at all. They are caused by a resistance plasmid. They are found in what we'll talk about this, Enterobacteriaceae, which is a very common group of organisms. And because of that, there's very few drugs that you can use. And when you're talking about these ESBLs, they are produced by the gram negatives. So they are produced by these organisms in the Enterobacteriaceae. Most of the plasmids, the genes coded for these enzymes are transferable among all these different bacteria. And so most ESBL isolates are resistant to many classes of antibiotics. And so the treatment of these is a challenge. Because again, you've got a lot of antibiotics that these guys are going to be resistant to. And that's one of the newer ones. Another one that we've seen come up recently, just even worse than our ESBLs, are the CREs, carbamazepine-resistant Enterobacteriaceae. And again, I'll introduce you to Enterobacteriaceae, but this is, your Klebsiella, E. coli. It's just your Enterobacters. They're just well-known, enteric bacteria. These guys have a different type of enzymes. There are types of CREs that are sometimes known as KPCs, Klebsiella pneumoniae carbamazepinase, the New Delhi metallobeta-lactamase. Oh, goodness gracious. And then the Verona integron-mediated metallobeta-lactamase. Yeah. Yeah. Basically, what happens is these bacteria become resistant to most available antibiotics. Most anything that we've developed. The death rate, if you can get infected with these, can be as high as 50%. Because we really don't have too much to treat with. And the Enterobacteriaceae is a large family of gram-negative bacteria. Includes your E. coli, your Klebsiella pneumoniae, your Pseudomonas aeruginosa. We'll talk about that. Causes ear infections and all kinds of stuff. Shigellas, that's your dysentery. We're going to get to look at these as we get into our lovely little diseases. Yersinia pestis, that is black plague. Okay, lovely like E. coli or salmonellas. So when you get these resistance, think of a Klebsiella pneumoniae, causes pneumonia. We don't have anything really to treat these guys with, so it's not good, and we usually don't have a good outcome. Okay. Most of these multi-drug resistant organisms are transmitted from patient to patient via the hands of healthcare workers. Yeah, nosocomial infections. So you need to be very careful when you're in these healthcare facilities that you are washing your hands between patients. And the worst ones have to be the doctors, although they're getting better and better at it. Okay. They are also spread via objects like the medicine carts, handles, the bed rails, the bedside tables, the IV poles, on and on and on. And direct contact with that particular, maybe a sore or something like that. The risk factors increases among the elderly and the immunosuppressed, patients with an existing severe disease, underlying disease conditions like diabetes or chronic kidney disease, prolonged use of antibiotics, getting an invasive medical device or having a procedure done, such as dialysis or getting a catheter or getting a port, repeated contact with the healthcare system, multiple hospital admissions, or an extended stay in the hospital. And then if you've been colonized with it before, that's not a good thing. What kind of infections can it cause? Just about any part of the body. All right. This is what we're dealing with now. It is of public health and clinical significance. About 10% of the hospitalizations are complicated with healthcare associated infections. Okay. Again, you will have a committee that will be looking at this and constantly, surveilling and going around and culturing areas to make sure it's not too bad, but we need to do it. As many as 75% of these healthcare associated infections are caused by organisms that are first line antimicrobial therapy resistant. Because again, we have all these people that are sick, they are getting IVs, and so the people are being the organisms are being exposed to these drugs. We've stopped a lot of the habits that we used to do way back when. I mean, it used to be you give somebody a shot, you draw the drug up in the shot, and you pull the needle out, and you squirt a little bit into the air. That's a quick way to say, microbes say, oh, I got some antibiotic I can get. Yeah. We've stopped doing that. We're much more careful. Um, but still, we've got a real problem with these antibiotic resistant guys. These infections result in about $20 billion in annual healthcare costs just trying to protect against these guys. Multi-drug resistance among the gram negatives is the most immediate threat. We've seen a significant increase in prevalence. And again, we have these different strains now that are a major problem. Your recombinant Enterobacteriaceae and multi-drug resistant strains of Pseudomonas aeruginosa and Acinetobacter. Almost half of the Acinetobacter baumannii is multi-drug resistant. Significantly worse outcomes. Mortality rate is up to 4 times higher than infections caused by susceptible strains. And you have the potential for widespread transmission because, again, you're in a hospital setting, you can spread it from person to person and ward to ward. I will tell you that there was a study done in Canada. This is the interesting thing where researchers sampled squid purchased from a seafood section of a food store, and they identified Pseudomonas fluorescens resistant to all beta-lactam drugs tested, including is the one that they were using. So here you have just a seafood section of a regular food store, regular grocery store, and the squid are resistant to the drug because these drugs are getting in our water supplies. And we're exposing, all these organisms and everything and to these drugs. This is not a good thing. And so they conclude there's urgent need for expanded resistance surveillance for these organisms and their plasmids in the food products. And we're starting to look at water sources and food sources and that kind of stuff. Just FYI, to let you know. How do we control the spread? Number one, hand washing. It's the most important way to prevent the spread. You're taught we're going to do a hand washing exercise. But healthcare workers are taught to wash their hands with soap and water or use alcohol-based hand sanitizer. They're also taught to clean their hands after touching a surface, blah, blah, blah. You have your PPEs, your protective equipment. You wear gloves. If a gown is soiled, you wear a gown or a lab jacket or something. You wear a mask when entering rooms if a patient has a drug-resistant infection. You have isolation rooms. Wash your hands before you leave. The main thing is careful use of the antibiotics. Use the antibiotics we mentioned only when we need it to and for the shortest time possible. This helps prevent the growth of more. Doctors are much more aware of this. Again, some of the patients are not too happy when they take their little kids in and they got a virus and they're told they can't be given an antibiotic and they're not happy. But we're trying to protect these people from getting multi-drug resistant infections. It used to be that a lot of times you would share a room. Hospitals would have double rooms. We've now pretty much gone to private rooms, and this is a reason for the private rooms. But if you have to share one, you may share a room with others who have the same infection. All the patient care items, equipment, room surfaces are supposed to be cleaned and disinfected every day. And you may have a checklist, particularly when a patient leaves that room needs to be cleaned and completely redone. The linens, the bed rails needs to be cleaned. So This is an important part of your maintenance people. They are a very important part of this. They need to be very particular about it, particularly if somebody has had one of these infections in that room. So, if you are a nurse and you're working with one of these patients and that patient leaves, please let the cleaning staff know that they really need to be particular about cleaning the room. You can get vaccinations against some of these. Strep pneumo, pneumococcal vaccine. I've had it. Just telling you. It's a type of bacteria that causes pneumonia. It's often resistant to one or more antibiotics. A vaccination can prevent these antibiotic resistant infections. So, when you get up there in age, go and get your vaccines. And again, we monitor. We have an infection control portion of the hospital whose job it is, and it's required by law. It's required by the agencies that inspect the hospitals that they show them their infection control logs. The lab will go and do cultures. We're required to go out and do environmental cultures to take a look at this and grow these out and let the people know, whatever floor, these are good. You have a water bath that you're putting patients with a wound in, that bath has to be cleaned every time. Is that bath clean? So we'll look at physical therapy, we'll look at surgery, we'll look at all the different areas of the hospital and culture them periodically. And then if there's a problem, we let them know. And that's, again, part of the environmental control that we're going to use to prevent this. Okay. We only use antibiotics when they're needed and as directed. And again, wash the hands carefully. Wear disposable gloves, gowns when applicable. If you visit a person in a healthcare setting, you should wash your hands upon entering before leaving that patient's room. Wear disposable gloves if you expect to come in contact with any of their body fluids. And you should wear a gown if it's required. But think about, most people don't think about it, but you need to educate the people. If you're going to visit somebody in a healthcare facility, you need to abide by these rules. That will help stop the spread of these guys. So hopefully this is giving you an appreciation for what you're going to be facing on maybe a daily basis working with these patients with these infections. And they're not fun. As I mentioned, one of the things we have found, and I didn't put it in the notes, is that, we're starting to see bacteria that are losing their resistance to penicillin, some of them. So one of the things we may be able to do is start rotating these antibiotics for a while. Just not use them, and now we can go back and use them for a few years and then go to the next and rotate drugs out. Because it's expensive, if you will, for the bacteria to maintain these resistant plasmids. They're little guys. They only have so much energy. They have a whole lot less than we do. So maintaining these resistant plasmids is expensive, if you will, for the bacteria. So if they don't see something for a while, they're going to get rid of it. It's just like us. We have something in our house we don't use for a while. It gets thrown out, hopefully. And this same thing will happen. And again, we are starting to see some of these organisms that are losing their resistance to these antibiotics that we stopped using years ago because we had so much resistance. So we may be able to start rotating these guys. But hopefully that gave you a little bit of appreciation for what healthcare is facing in terms of these resistant organisms and makes you more aware.